Okay, welcome to our wonderful event tonight. Here at Hoag, we're hosting a great panel of physicians as well as our wellness coach at the end of our program. So thank you so much for joining us tonight. Our topic is innovation and inspiration for metastatic breast cancer patients. My name is Dr. Sadia Khan. I'm our Director of Integrative Breast Oncology here at Hoag. So I also lead our survivorship program called Hoag Healing Breast Cancer Survivors. We have a team that we've put together, which is philanthropically funded. We typically, when it's not COVID, have in-person events throughout the year for all patients and their family members who have been diagnosed with breast cancer. We tried to have an empowerment series, which this topic is part of, and then also some other supportive events. So everybody who's registered will get a newsletter to their email tomorrow with other upcoming events that we'll be having, so please look out for those. Again, we have a wonderful panel for you guys tonight. Please keep in mind that you can be interactive with our program. Please take any questions or comments that you might have and save them for our question and answer session at the end of our speakers. So please log in, write down any questions, and we'll be able to hopefully answer most of the questions tonight. So without further ado, I'd like to introduce our wonderful panel. We have our wonderful physicians that are joining us. So Dr. Louis van der Molen is our Director of Medical Oncology, Dr. Vincent Nguyen from Palliative Care, and Dr. Shane Lloyd from Radiation Oncology, as well as Anusha Wajayakumar, our wellness consultant, who will be giving a wonderful positive meditation at the end of our panel discussion. So without further ado, please, Dr. van der Molen, go ahead and introduce yourself, and then I'll let the other speakers introduce themselves quickly, and then we'll get started.
So I'm Dr. Louis van der Molen, a medical oncologist, previously at the National Institutes of Health in Bethesda. Came to Hoag in 1991. I'm one of the original founding oncologists of the Hoag Family Cancer Center, and I am medical director of oncology at Hoag Family Cancer Institute.
Great, thank you so much. Dr. Nguyen?
Yes, hi, I'm Vincent Nguyen. I am a board-certified hospice and palliative medicine specialist with certifications in geriatrics and family medicine. And I oversee the inpatient and outpatient palliative care program here at Hoag. In addition, I'm also an assistant clinical professor and a founding member of the UCI Hoag Palliative Medicine Fellowship. Happy to be here.
Wonderful, thank you. And then Dr. Lloyd, tell us a little bit about yourself.
Sure. I'm Shane Lloyd, one of the newest members of the radiation oncology team here at Hoag, working at both Newport and Irvine. Before this, I was at the University of California, San Francisco, and completed my medical school and graduate school training in Pennsylvania.
Wonderful. Okay. And then Anusha, tell me a little bit about tell everyone what you do for us at Hoag.
Thank you, Dr. Khan. My name is Anusha Wijayakumar, and I'm the wellness consultant for the Women's Health Institute. I lead on all of the meditation and mindfulness for Dr. Khan's survivorship program, our Pre-Viva program, as well as our maternal mental health program. I also work with the Neurosciences Institute and at our Hoag Acute Rehabilitation Unit.
Wonderful. Thank you so much. All right. We'll hear more from Anusha towards the end of our program, but without further ado, I'll let Dr. van der Molen start with his topic. So tell us a little bit about the most innovative treatments for metastatic breast cancer patients.
So first of all, I think when we talk about metastatic breast cancer, we have to understand that it's really a very big category of diseases, a big group of diseases. It's a very much a mixed bag of diseases. There are some women who we call having oligometastatic disease, which means they have stage 4 metastatic cancer, but it's minimal, maybe up to 4 sites in the bone or 3 sites in the liver, a solitary metastasis in the brain, or perhaps just nodal involvement. And these women can be treated toward very long, prolonged remissions and even potentially cure. The next group that we would think about are patients that have more established metastatic cancer. There may be several areas of bone or liver or a combination. And the goal of treatment there is really more directed toward quality of life and prolonging life, but the state of the art would not really offer a cure for those women. And then lastly, there are women who have stage 4 metastatic breast cancer who present with almost a crisis, that the disease is involving an organ and causing organ dysfunction to the degree that initiating treatment becomes really an emergency. Other than that, without initiating treatment, patients can rapidly die of their disease. When we think about these cancers, we kind of divide them up into 4 different groups: luminal A, luminal B, HER2 positive or triple negative, and they all have different natural histories. We can expect them to behave certain ways, and we have different tools to treat these different cancers. Luminal A's are kind of slower growing, less aggressive, often responsive to hormone therapy. Luminal B's also respond to hormone therapy, but they tend to be a little bit more aggressive cancers. HER2 patients are those that have a gene, an oncogene called HER2/neu, and we have a completely different set of tools to treat those patients. And lastly, the triple negative patients, that is, they're negative for both estrogen receptor, progesterone receptor, as well as HER2. But there's also newer agents and newer treatments available for those women, especially the triple negative patients who have stage 4 disease. So the tools that we have as far as the treatment options that we have as far as managing patients with stage 4 breast cancer are surgery, and that is operate and remove the cancer. It could be liver, we can do a resection. It could be lung surgical resection. Certainly brain can be surgically resected. The next tool would be radiation therapy, and in particular, sometimes localized radiation called CyberKnife, kind of like a laser beam of radiation that's very focused on one side of disease. There's a procedure called radiofrequency ablation, where a needle can be put into the cancer that microwaves or burns the cancer. If there's 1 or 2 lesions, say in the liver, that can be a very effective tool. And then as far as whole body treatments or systemic therapies, of course, there's hormone therapy, drugs that block estrogen receptor and tumors that are driven by estrogen. There's chemotherapy, drugs that are injected in the bloodstream that kill cancer cells. Immune therapies, drugs that work through the immune system to help the immune system better identify cancer cells and eradicate them. The targets that we use, a number of different targets we use to personalize the approach. So no 2 patients are necessarily treated the same because no 2 cancers are the same. We have a number of targets that we look at within the cancer itself. Estrogen receptor being a target for hormone therapies. HER2/neu is the oncogene that we can target with antibodies, sometimes conjugated drugs, an antibody that's conjugated to a toxin. In triple negative cancers, we often will treat with immune therapies and analyze the tumor for something called PD-1 or programmed death 1. And then there are other targets that we look at, one called PIK3CA. That's a mutation within the cancer. If the cancer has that mutation, it's very likely to respond to oral targeted agents that work directly toward this particular mutation. And then lastly, in the triple negative group, we also have a new antibody that targets what's called topo2. 90% of triple negative cancers will express topo2. It's an antibody that targets topo2 and binds to this protein on the surface of cells and causes cell death. So again, we look at cancers, look at patients to see what the extent of disease is. We look at cancers to see what kind of characteristics they have, and then treatment becomes very personalized based on whether or not certain therapeutic targets exist on the surface of the cancer cells.
Great. Thank you for that wonderful talk. So Dr. Vandermolen, as a breast surgeon, I don't typically get to see very many metastatic breast cancer patients, but I know you get to see many more. But would you say 25% of newly diagnosed early stage breast cancer patients, up to 25%, may actually have metastatic disease upon further workup? Is that what you see in our community as well?
Yeah, so they can, patients can develop metastatic disease having had initial early stage disease, stage 1 or stage 2, and then later relapse with stage 4 metastatic disease. But about 20-25% will, at initial diagnosis, will be discovered to have stage 4 disease at the time that they come to presentation or are evaluated for their breast cancer.
I know you and I have shared quite a few patients that have had metastatic breast cancer and have done really well. So I just want to, emphasize that there is treatment for metastatic breast cancer. And, here at Hoag, we do have some wonderful, innovative treatments, physicians. And are there any clinical trials or anything that we should know about that are up and coming, Dr. Vandermolen?
Well, there's a number of clinical trials, particularly in the triple negative subset of patients. A lot of the clinical trials are for sort of second or third line treatment. So if patients already had treatment, then these are options or alternatives a little bit later down the road. But absolutely, not everybody with metastatic breast cancer, not everybody with stage 4 breast cancer will succumb to their disease. And here at Hoag, we have a number of women who've been treated, and it's 20 years, 25 years, and they're alive, well, and have no cancer.
Wonderful. Thank you so much. All right. So Dr. Lloyd will go ahead and let's hear a little bit about where radiation plays a role in treatment for metastatic patients.
All right. Thank you, Dr. Khan. Yes, radiation therapy, sort of unlike the type of treatments that Dr. Vandermolen can offer, which go in the vein, taken by mouth, and act all over the body. Radiation therapy is a local treatment, and I'll sort of talk a little bit about the role for radiation therapy in the metastatic setting. So we can go to the next slide. A lot of people may be aware of the role of radiation therapy upfront during the initial diagnosis of breast cancer. It's a fairly common cancer, and people may be aware of having surgery and plus or minus some chemotherapy afterwards, and then radiation therapy to the whole breast. This is something that may take place over the course of several weeks. And it is, a very effective treatment that we've had around for decades. The actual techniques and the way that radiation is delivered hasn't really changed in a major way over the decades, and that's really because it is so effective. But there have been lots of developments here in the last 10 and 5 years about how we can give more focused type of radiation therapy, and really finding a lot of applicability in the metastatic setting. So if we go to the next slide. This concept of oligometastatic disease really is an interesting frontier for focal types of radiation therapy. And this is really patients who have just one or a few sites where cancer has spread to other parts of the body, and they're otherwise doing pretty well in terms of the control of the main site of their disease, in this case, say in the breast. And there have been studies that have come out recently showing that if you aggressively treat the main site of disease and these metastatic sites, these patients can actually do very well and may actually even live longer than sort of the previous paradigm that was, well, if cancer is spread to other areas, it's sort of a palliative paradigm. And that's where radiation therapy comes in, both for the treatment of these oligometastatic sites, but then also in maybe more the traditional sense, sort of focal treatment of painful areas of disease, or places where there's just enlargement, but other sites are under control. So we can go to the next slide. The different types of techniques of radiation we can use in the metastatic setting really vary from larger fields to smaller ones. In terms of smaller, more focused type of radiation, we can do something that is called SBRT, or stereotactic body radiation therapy. And that's sort of a very fancy way of saying the ability to very precisely deliver a high dose of radiation over a short period of time, usually 1 to 5 treatments. So we're not talking about the weeks and weeks of treatment. We're talking about short duration of treatment with a high dose. And when we do this type of treatment within the brain, if a patient has brain lesions that have formed from their metastatic disease, we can do a type of stereotactic treatment within the brain, stereotactic radiosurgery. And the brand name or the machine we use to do that is called the Gamma Knife that we have here at Hoag. And that allows us to treat brain lesions in a single session, 1 day. We can treat 1 or multiple. And then something that is sort of new and exciting in the realm of this SBRT here at Hoag is the ability to leverage new imaging technologies. So MRI, magnetic resonance imaging, allows us to obtain very high resolution images of soft tissue, more so than we can with X-rays or or CT scans. And we actually have some new technology coming here at Hoag that combines our ability to deliver radiation therapy with MRI in a single machine. So we go to the next stage or next slide. This machine is called the ViewRay Meridian, and it actually combines a linear accelerator, which is the machine that delivers radiation therapy, with an MRI. And you can see in this image here that sort of hole or bore in the middle is where the patient lies, and then the sort of device around it is the MRI plus the linear accelerator. So it's all put together. If we go to the next slide. This machine, the ViewRay, with this onboard MRI imaging is really sort of changing the paradigm of how we're able to treat with this SBRT for patients with metastatic disease, because we can get high quality images of the tumor as well as the organs that are nearby them. And this is very exciting because previously we were sort of depending on X-ray imaging or CT scans, and you can see it well, but not nearly as well as you can with an MRI. So having the MRI combined with the radiation treatment machine allows us to precisely set up the patient every day to exactly where the tumor is. We can actually control when the radiation beam is on in time with a breath hold of the patient, so that we're treating a smaller volume. And we can also, for the first time, very easily change where the dose of radiation is going on a day-to-day basis, depending on the patient's anatomy that day. So in the next slide, we can see an image here. The sort of red circle there is the target or the tumor, and the blue is where we want to treat. And so the patient here has actually held their breath. And in this time, when the red area is within the blue, is when the radiation beam is on, delivering the radiation to the target. And then when the patient starts breathing again and the tumor moves outside of the field, the beam will turn off. And so this allows us to treat a much smaller volume of tissue, reduce the dose that's going to other organs nearby, reducing the toxicity, and also allowing us to give a higher dose, which makes it more effective. If we go to the next slide. We can see, I mentioned this daily variation in anatomy, and it can be quite dramatic. So if we have a tumor, the T there, and this could be, for example, a site where metastatic breast cancer has spread and we're trying to treat it. Well, day to day, when patients coming in for their daily treatments, the S, that stomach there, could be in very different locations depending on, even if you've had a drink of water, you've had a meal earlier that day, or some gas bubbles, and now that stomach could be right up against where the tumor is that we're trying to treat. And this could cause some issues depending on the dose we're trying to give to the tumor. So by being able to visualize where the anatomy is every day, we can tailor the dose that they're going to get that day to ensure the maximum possible dose, but also the safest dose. And go to the next slide. This again is just a diagram showing how we can shape the dose. So the sort of red squiggly lines you see in the middle of the screen are actually the dose distribution of the tumor we're trying to treat. And then the other shapes around are nearby very sensitive organs. And between day 1 and day 2 of treatment, we can actually change the shape. This will be very important in this oligometastatic setting of being able to aggressively treat these sites where disease has spread, give them the maximum possible but safest dose. Can we go to the next slide? So just to sort of summarize it all, radiation therapy is obviously very important for breast cancer patients upfront with a new diagnosis, non-spread, but also in the metastatic setting. It can be used to help improve quality of life by spot treating those problem areas that maybe are very painful, such as in the bone. But they could also be used, for very aggressive treatment of oligometastatic disease. And then the ability to use MRI with this new treatment machine that we have coming here at Hoag is a very exciting opportunity to allow us to really tailor treatment to these patients. That's it. Thank you.
Thank you so much, Dr. Lloyd. That was very interesting to hear more about the ViewRay. I've heard so much about it. I know many institutions don't have the opportunity to offer that to patients, but here at Hoag, through philanthropy, we've been able to acquire the device, and then hopefully we'll hear more great news updated for our patients as things go along. So thank you so much for your talk. To the viewers, please participate and submit any questions that you have for our wonderful panel. We'll get an opportunity to do some question and answer, and we'd love for you guys to participate. So please join in and submit any questions. We will keep going with our program. So Dr. Nguyen, please talk to us a little bit more about your program and what you can offer metastatic breast cancer patients at Hoag.
Great, thank you. When you first think of metastatic breast cancer, some people will ask what does palliative care have to do in patients who has breast cancer? Next slide. So palliative care is a team approach, and this is my team. As I introduce myself, I direct the inpatient and outpatient palliative care services, and for both of the Hoag hospitals in Newport Beach and in Irvine. And we also have an outpatient clinic, and it takes a whole team of people. I have a team of social workers, team of doctors, team of nurses, and a chaplain, as well as administrative assistants. So next slide. In these next few minutes, I'm just going to share with you, we have a few objectives. First of all, we're going to define what palliative care is and how is that different than hospice care. And we're going to describe how integrating palliative care and with standard oncology interventions can benefit patients and their family. Next slide. So when we talk about palliative care, it's not an easy term to define. So I have to define it in 3 different ways, in 3 different segments. So the goal of palliative care is to provide a better quality of life and relief from symptoms and stress for people living with their serious illness. And that's the goal of palliative care. And then what is it? So it is an interdisciplinary approach. That means there's a team of people that are involved in the person's care to address the emotional, the spiritual, and practical needs and goals of the patients and the people close to them, such as their friends and their family. And the beauty of palliative care is you don't have to give up receiving chemotherapy or radiation. These palliative care is provided along with these curative intent that Dr. Van Holen's team and Dr. Lloyd's team are attempting to do. And how is it delivered? Well, it's as I mentioned, it's administered by a multidisciplinary team comprised of palliative care specialists. Palliative care is a medical specialty that focuses, again, in caring for people, helping people live well and live long. Next slide. So when you think of palliative care, some people think of end-of-life care, some people think of hospice care. These are really 3 distinct types of care for people living with serious illness. There are differences, but there are also some similarities. Next slide. So when you think of palliative care, you think of this big, huge circle. And within the palliative care is end-of-life care or hospice care, within hospice care. So as you can see from this slide, hospice care is palliative care, but palliative care is not hospice care. So with the palliative care approach, it's about how to help relieve patients and family from the symptoms and stress of a serious illness. So hospice care also focus on that as well, is how do we help people live well and live long? But as doctors, we know we can't give people immortality. Sometimes the illness just gets out of the way. And then as the disease trajectory progresses, how do we provide the best care possible for patients as the disease worsens? And this is where hospice comes in which hospice is for people living with a prognosis of less than 6 months and their curative focused treatments have been exhausted. Another way for me to explain this is through the next slide. I'll give you a different way of explaining what palliative care is. So how do you time palliative care? When is it appropriate for me? So the goal of medicine is when a person's first diagnosed of a life-threatening illness or a debilitating illness injury, the goal of medicine is to provide treatment to modify the disease, to slow it down in the hope of curing it. And the other piece that we need to focus on is called supportive care. So as you can see, this wiggly red line, anything above that is disease modifying treatment. Anything below that's called supportive care. And next slide, can you just push it once? And this supportive care is really called palliative care. So this can be provided along with chemotherapy and radiation. Next slide. And so where does palliative care fit in and hospice fit in all this? We recognize that at some point when the disease progresses toward the biological death of a person, hospice can play a critical role in providing the support and for the family. So palliative care here in hospice is really a whole coordination, or at least a continuum of care, as you might say. And after the person dies, next slide, is we talk about bereavement. So this is how I see palliative care hospice as a continuum and how it plays a role in your treatment. Next slide. So people often ask, so I'm worried about palliative care. What is it going to be talking about? Is it all about death and dying? And the answer is no. Our goal as a team is to help understand what people are going through, what are their hopes, as well as the fears and the worries. How are they coping, and what kind of support do they have? We recognize that palliative care is a team approach, but in the patient's care, there are people outside the hospital or the clinic setting who's caring for that person at home. How are they doing? And we also focus on pain and symptom management. As patients go through treatment, sometimes they do have pain and side effects from the treatments. And our goal is to alleviate or at least palliate it, to make it more tolerable so that a patient can continue to receive those treatments in a hope of living long and living better and living well. And the other piece we talk about is advanced care planning. It's about kind of planning for the future. Next slide. So what are some of the obstacle myths and fears about palliative care? We often hear that, well, Vince, patient and family are not ready for palliative care yet. Because, when we start talking about palliative care, people think that, well, this is the beginning of the end. Let's not talk about it. Because as we think about palliative care, people think that, well, it's going to take away people's hope. It provokes emotions of fear. Is my physicians abandoning me? Am I dying? If I get on palliative care, it's going to reduce my survival. That means I'm going to die quickly. But these are obstacles, myths that need to be overcome. Next slide. We see that palliative care is associated with better quality of life and overall survival. Next slide. There's a study that was published in the New England Journal of Medicine by Dr. Tamel about 10 years ago. It looked at early palliative care for patients with metastatic non-small cell lung cancer. Even though we're talking about breast cancer here, but I think there's a parallel correlation here. Next slide. What they found is that patients who receive standard oncology treatment versus those patients who receive early palliative care along with their treatment. When we say early palliative care, is the palliative care is treated early in their trajectory of the illness. People are living happier with more functional and less pain. They don't spend a whole lot of time bouncing back between the house and the emergency room or the intensive care unit. And what they found was amazingly, which we who work in palliative care know, that people actually do live longer when they receive palliative care. The median survival is almost 3 months longer than those who don't receive early palliative care. Next slide. So the summary of this is palliative care is about hope. It's a team approach on how to help people live well, and it helps you improve survival and also improve people's quality of life. Thank you.
Thank you so much. It's nice to hear the differences, and I think that's an important distinction about palliative care and hospice. So thank you for your talk. And I think you touched on an important topic. Everything about treatment with breast cancer and other types of, obviously, cancers, but specifically for metastatic patients, it's very important to use the team approach. And I think Hoag does that very well. And, you know, I have the honor of working with all of you guys as great physicians, and, you know, any of our patients that are coming to Hoag will have the opportunity to meet with a team of physicians and other staff members that can help guide their treatment. So I'm going to move to our question and answer session. We have a few questions for our panelists. So please, viewers, if you have any other questions, this would be a great time to submit them. I'm going to go through the questions that I have. So I'll start with the first one. So Dr. Van der Molen, can you tell me a little bit about the goals of treatment with metastatic breast cancer? Can you talk a little bit about whether it's meant to be curative, or what maybe your goals are when you are evaluating a patient and coming up with a treatment plan?
So patients who present with limited disease, oligometastatic disease, again, several sites of disease in bone, or perhaps 1 or 2 sites of disease in liver, or solitary lesion in the brain, they can be treated with the intent of significant prolongation of survival and actually cure. Those are patients that can be cured with a multimodality approach. They'll need surgery, they'll need possibly radiation or another local maneuver like a radiofrequency ablation, and they'll need a systemic therapy, at least for some time, not necessarily for their lifetime. But those patients can be treated with intent of prolonged survival, significant prolonged survival, and cure. On the other hand, patients that have more overwhelming disease, disease in bone, liver, lung, at multiple sites, there the goal is really to enhance quality of life and prolong life as long as possible. You know, we look at the different characteristics of the cancer, and of the different characteristics, we talk about what our treatment options are. We try to use options that are least likely to result in any kind of toxicity or side effect, and most likely going to allow the patient to remain in good quality of life for as long as possible. And as time goes by, we may have to advance to other treatments, but the goal is quality of life and certainly prolonging life in that set of patients.
Okay, thank you. All right, so our next question is for Dr. Nguyen. Can you tell, so if a patient comes to see you for a palliative care visit, can you tell us a little bit about what that looks like and what they can expect from that appointment?
Yes, thank you. So patients who come in to see us, they usually see myself and my social worker, and as well as my nurse as well. Because as I mentioned, this is a team approach because we really want to understand the supportive mechanism and how is the person being supported at home. I mean, we focus a lot on the medical piece, but the psychological becomes important too, the social needs. My nurse and I, we focus mainly on pain and symptoms. You know, how is, you know, we want to understand what our people are going through, how's the treatment affecting them, what are their pain, what are their fears. A lot of people maybe fear, well, I don't want to take opioids because I don't want to be an addict. You know, so we explain to help people understand that the goal of medicine is to alleviate your discomfort, and the medications will be given proportionately to your pain. And we spend a lot of time educating people about the different opioids that's used, the common side effects. And I want to empower people to keep track of their opioid use so that when they come back, so we can keep track of this, so that we can titrate the medication or increase and even decrease the medications based upon how their body's needs. And I usually follow up with patients in about 2 to 4 weeks, depending upon their symptoms. And patients will always have access to us. You know, even though we're not a 24/7 service, we see ourselves as an additional layer of support to the treating team, but we're here to help with pain and symptom management and supporting the family as well. And I have to say that I keep on bringing up the social workers because we're very lucky here at Hoag to have a team of social workers. Because once you see one palliative care, you see one palliative care program because we're not all the same. I think sometimes we focus a lot on the medications and the medicine part, but we forget how the emotional or psychological aspect of it is the person's illness affecting them, who they are, and how it interacts with their family members as well.
Yeah, I think that's an important point. Thank you so much. All right, we have a question from the audience for Dr. Lloyd. So the question is, can you elaborate further on the use of radiation to eradicate lung nodules? And they were requesting more details. Does the nodule have to be a certain size or in a certain area of the lung? So I don't know if this is maybe a joint question more so for Dr. Vandermolen or Dr. Lloyd or both, but it was actually addressed to you, Dr. Lloyd.
Okay, sure. Yeah, I mean, I can weigh in first. So yeah, metastatic disease that's in the lung can be amenable to several different treatments. Certainly, if there are a lot of lesions, systemic therapy, that is chemotherapy, immune therapy, etc., may be appropriate. If there is a limited number of lesions, and there may be a consideration for doing a surgery to remove part of the lung that contains that lesion. And then also, yes, radiation therapy can be used as well. And that's really a case where we would use that SBRT that I mentioned, the stereotactic body radiation therapy. Usually would be 3 to 5 treatments of very focused radiation therapy just on that lesion. And it's typically very effective, 90% or more effective at controlling that lesion. And it is important to know that radiation it's a local treatment. It only works where it is pointed. So it's not going to stop something from coming up somewhere else, but it would be very effective for that lesion. And in terms of the location, yes, radiation therapy can be used if the lesion is in the periphery or the outer portion of lungs, say up near the chest wall or the rib, or more centrally. The only thing I would say is when we're treating lesions that are closer to the center of the chest, nearer to the heart, the esophagus, or things like that, we just have to be careful about how we deliver the dose. And that is really a situation where something like the MRI guidance on our new machine, like I mentioned, would be very helpful to allow us to keep dose out of the heart and the esophagus, for example. But they certainly can be treated at any location, yes.
All right, great. Thank you so much. Dr. Vandermolen, another question for you. So what are other treatments for breast cancer that has spread to the bone besides radiation therapy?
So you treat the cancer of the bone, and it may be hormone therapy, it may be an anti-estrogen, it may be immune therapy, it may be HER2 directed, and the cancer will go away. But there will be an area in the bone that's abnormal where the cancer previously resided. And so we have a number of agents that stimulate new bone formation. So these are drugs, they can be, some are pills, some are injections, some are shots. They work differently through different pathways, but what they do in one way or the other is stimulate certain bone cells called osteoblasts and causes those cells to grow and repair the bone and heal the bone and make the bone once again structurally strong so it's not at risk for breaking or fracture.
Great, thank you so much. There's a question, I think I can go ahead and answer this. The question from the audience was, I've been diagnosed with stage 1 breast cancer. How do I know the cancer cells are not in other organs, or how do I know I don't have metastatic? So I think, initial workup for breast cancer when you're early stage really goes straight to surgery, radiation treatments along those lines. But once there's evidence that the breast cancer has spread to the lymph nodes, and eventually once patients are seeing Dr. Vandermolen and getting a further workup, they might undergo CT scan or PET scans to look for disease elsewhere in the body. So initially, unless you've had a complete workup, you wouldn't know the answer to that question. But as you go along in your treatment and workup, you will eventually, hopefully, get full body scans, and that's how that is determined. So we'll keep going with our questions. Dr. Nguyen, can you tell me a little bit about, I know you kind of touched on this in your talk, but can you just give me a little bit of a brief discussion about where palliative care plays a role with patients who have metastatic disease in their oncology treatments? Like, how do they play hand in hand, and where do you fit in there?
Yeah, so we are the extra layer of support in terms of, how do we help patients and family as they're going through, where I have to emphasize the word patient and family, because again, it affects not only the patient and the family, but also their family. I'm sorry. Our goal is to help with pain management, and sometimes a lot of side effects from the treatment. People may develop nausea, decreased appetite. Sometimes with an illness, they develop anxiety, they can't sleep. So these are common symptoms that we address. And how do these affect them emotionally and psychologically? And for some of the patients, sometimes it's more a matter of, are there resources? Are there resources in the community that I need to help for caregivers? What kind of resources are available? And this is where our team can come into, our social worker team can help identify some of those resources to help patients' family to care for them better.
Okay, great. Thank you. Dr. Lloyd, can you tell me a little bit about, if a patient's been previously radiated, their question is, can they still have radiation again if they've had a previous history of radiation therapy?
The answer is yes, although it can get more complicated. So if we're talking about reirradiation of the breast, say a recurrence, which can happen even with surgery and radiation therapy, it is possible to have a recurrence. In those cases, we'll often talk about repeating surgery, although there is a possibility actually to do reirradiation of the breast itself safely and well tolerated. In terms of other sites, say a patient has surgery radiation to the breast up front and then sometime later has a metastatic recurrence, they certainly can have radiation to those sites very safely. As I mentioned before, radiation is a local treatment, so the effects are really confined to the area where the radiation was received. So if somebody had a metastatic lesion down on the hip in a bone, that is not a problem. And even if there was a lesion in the rib, which might have been in the radiation field, we have techniques, as I've been talking about, to do very focused type of radiation that would be safe and effective. So yeah, it's still an important tool even after someone has had radiation before.
Okay, great. Dr. Vandermolen, tell me, one of the questions is, what are some of the factors that you consider in making decisions? I know you discussed a little bit about the sites of disease and how much metastatic disease is present, but is there other information or things that you look at when you're evaluating a new patient who has been diagnosed with stage 4 breast cancer?
So the sites of disease is important. Certain sites are more likely to respond to certain therapies. And then the characteristics of the tumor, whether or not it has the estrogen receptor or it doesn't, whether or not it has HER2 new amplification or it doesn't. Is it a triple negative cancer? We usually do molecular testing on these tumors. So we procure a piece of tumor by biopsy technique, and we analyze that for about 100 different genes. And based on that genomic makeup, we can better identify what treatment options exist and what the best treatment options are. And then based on that analysis, we would choose the treatment that's most likely to be effective, but also least likely to interrupt the quality of life and least likely to result in any major toxicities or side effects. So it's complicated. It's based on sites of disease. Certain areas like bone are more likely to respond to certain therapies than others. It's the extent of the problem in the person's body, the characteristics of the tumor, does it express or not express estrogens, looking at these other antigens like PD-1, PIK3CA, a number of different markers or genetic abnormalities that help determine what the most effective and best treatment will be.
Okay, great. Thank you. All right. If there aren't any other questions from the audience, I'd like to move on with our program and have Anusha Kumar move on and give us a meditation to end our program. I've worked with Anusha quite a bit with our Hoag Healing program. Just a quick reminder to the audience, we do have multiple virtual events now that we've moved out of having in-person events, which we definitely miss and hope to restart in the near future. But we do have quite a few virtual events. We do different topics every time, so please look out for your email to register for any of our upcoming virtual events that are relevant for all breast cancer survivors. So Anusha, I'm going to let you go ahead and get started, and thank you for being here tonight.
Thank you so much, Dr. Khan, and thank you to all of our amazing physician presenters today. I am honored to be leading a meditation. So just a little bit of background before we begin, because I'm often asked by our patients, what is meditation and how effective can it be? I mean, honestly, meditation is one of the greatest tools that you can have to develop greater resilience and to really work on finding that balance and equanimity within, which we all need over the past year, I would say more than ever. So I'm going to be leading one of my favorite, very simplistic 5-minute practices that focuses on the breath. And this is one that you can utilize every day. I'm also often asked, is 5 minutes enough? 5 minutes is more than enough, because think about it. If we say to somebody, you have to be in a meditation practice by doing it for 15 minutes a day, they're not going to do it. And quite frankly, even when I tell people to do it for 5 minutes a day, they're not doing it. So just start to think to yourself, and I invite you all, do the 7-day challenge. We begin today. For the next 7 days, commit to doing a 5-minute meditation. I guarantee that you will start to feel a difference in your mind and your life, very subtly at first. But to me, meditation just helps us to get through our day and to become less reactionary. And I think that's something that, again, we can all do with so many things changing every day. How do we find that balance? And the balance has to come from within, if we think about this in the context of meditation and mindfulness. Secondly, you can meditate anywhere. So I highly recommend, if you're not already sitting in a chair, to actually come to sit in a chair. It's more comfortable than sitting on the ground, because for most of us, we're not used to sitting on the ground. The only rule in a meditation practice is that the spinal column must be in a neutral position. So if you're sitting in a chair, just get comfortable here. We're not slumping back. We're not relaxing. You're not sitting on the sofa just yet. And if you are, then please sit up straight. Legs are uncrossed. Soles of the feet are planting. And I just invite you all to just gently press the palms down on top of the knees. You can close the eyes if you wish. I always recommend that you close the eyes, as that just helps to withdraw one of our main senses of sight. But if that doesn't feel good to you, that's absolutely fine. You can just withdraw your sight by staring at a focal point on the ground. So wherever you are now, just get comfortable. And we're going to begin with 3 deep inhales and 3 deep exhales. So exhale all of the air out of the lungs. And then begin a deep inhalation through the nose and a loud, audible exhale through the mouth. So sigh that air out. That's actually what activates the parasympathetic nervous system response in the body, which is the aspect of our central nervous system that calms us, moving away from fight or flight to rest and digest. So 2 more times, deep inhalation and that audible exhalation, really sighing that air out. 1 more time, deep inhalation through the nose and a loud, audible exhale. And just return to your normal rhythm and pattern of breathing as we allow the mind here to come into that place of stillness and of quiet within. Letting go of the day that has been not worrying about what is to come, just anchoring yourself in this present moment as you gently relax the shoulders down away from the ears. You relax and release the muscles in the face, any tension in the neck, the jaw area, releasing the tongue from the hard palate of the roof of the mouth, releasing the point between the eyebrows, and just taking a moment to fully arrive into the physical body, into this moment, focusing on your breath, which is your anchor in the changing tides of life. It's what keeps us balanced. It's what brings our body and mind together on the inhalation and the exhalation. If thoughts are coming into the mind, that is completely fine and normal. But just allow those thoughts to drift away like clouds in the sky as you return to your body and your breath, your body and your breath, your body and your breath. And I want you all in this moment to relax, because there is no doing this practice wrong. If there are any external sounds, just let them be. And start to notice the shape, the weight of your breath in your body, the gentle rising and the falling. And just notice how your breath feels in your body. Is it long and smooth, or is it short and shallow? Just notice. You're not trying to breathe in any particular way right now. You are simply breathing as it comes. There are no need for judgments or opinions here. If you have them, just allow them also to drift away like clouds in the sky, returning to your body and your breath. You will soon be inhaling for my count and exhaling for my count. So gently exhale all of the air out of the lungs. And then begin the inhalation through the nose with the mouth closed for the count of 1, 2, 3. Exhale through the nose with the mouth closed for 5, 4, 3, 2, 1. Inhale. 1, 2, 3. Exhale. 5, 4, 3, 2, 1. Continue that breathwork pattern for 3 more rounds at your own pace, to your own count. So you're inhaling for the count of 3, and you're exhaling for the count of 5, going at your own pace. And if that feels too much, just go to whatever count works best for you, just ensuring that the exhalation is longer than the inhalation. And as you inhale, I want you to silently repeat to yourself, I am at peace. And as you exhale, I want you to silently repeat to yourself, all is well in my world. I am at peace on the inhalation. All is well in my world on the exhalation. And just allow yourself in this moment as you inhale to feel a sense of peace washing over you and comforting you right now. And on the exhalation, feel that all is well in your world, regardless of your external situation or circumstance. You are at peace on the inhalation. All is well in your world on the exhalation. Once you've completed your 3 rounds of that breathwork pattern, release, returning to your normal rhythm and pattern of breathing. So we just take a moment to absorb our practice. Slowly start to bring your consciousness, your awareness back to the physical body. As you gently start to invite some movement back in, perhaps gently turning the head from right to left, wiggling the toes, the fingers, feeling the weight of your legs on the chair, the weight of your arms on your legs, the weight of your head on your neck, as you slowly and gently blink the eyes open, returning to the physical space you are in. So that's one of my favorite mindfulness meditations, focused on the breath. It's one that even if you can't remember everything that I have said, you can just focus on that inhalation and the exhalation, just ensuring that the exhalation is always longer than the inhalation. I hope you enjoyed that, and I will now hand back to Dr. Khan.
Thank you so much. I feel so relaxed. So we hope the viewers have enjoyed our program. From our panelists, answering all of these great questions and talking about our wonderful treatment options for our metastatic patients. And then Anusha, for your wonderful meditation. I do have a fun announcement. We are actually through philanthropy. So we have some wonderful donors who have supported our Hoag Healing Survivorship Program. And we are offering a monthly podcast that Anusha will be giving directed to our metastatic breast cancer patients at Hoag. It's going to be complimentary. Everybody who's registered for the event tonight will get an email with a link for the first podcast. My understanding, Anusha, and correct me if I'm wrong, every month they will receive a podcast that you've put together that has a different intention and some positive thinking and a lot of, basically a meditation. And they'll also have, you guys would also have the opportunity with one event with Anusha, kind of like for a live coaching session that she'll introduce later on in the month. So we're really excited to introduce this program. We are looking forward to your feedback to the meditations that you'll be receiving monthly. We hope you enjoy them. And then obviously also the live question answer that you'll have with Anusha directly. And if you have more details, Anusha, please correct me if I misspoke.
No, thank you, Dr. Khan. That was perfect. I think what we're really trying to do through our generous donors and philanthropy at Hoag is to provide community. And we know that we really need that in this time of 2020 with a pandemic and with everything else going on, that need to feel a connection to one another. And we're specifically actually offering this to our metastatic breast cancer community. It's an honor for me to be able to lead this. The podcast every month that you will receive, as Dr. Khan mentioned, is actually focused on intention setting. So every month we will live with a different intention together. There's a little practice that I provide as part of the podcast and some inspiration around meditation and mindfulness. And then we'll have an opportunity to come together every month that is also complimentary in a Zoom environment where we can really unpack the month's intention and come together in community to discuss, whatever is on your mind. So I hope you'll join me. Dr. Khan mentioned the details will be being sent out to you, and I'm excited for our first workshop this November.
Great. So if anybody who's watching has any questions or concerns, we do have a contact page. If somebody can put up that slide with a phone number and an email. If you have questions about this program or any of our future programs, Stacy Patterson is our clinical breast cancer nurse navigator at the Cancer Center, and she can tell you more about any of our virtual events that we have coming up with Hoag Healing or our podcast that we mentioned. And once again, I'd love to thank our wonderful speakers tonight for taking the time to put together these great talks. If you want to go over this talk from tonight or any of our previous virtual events, you can find them on the Hoag Health YouTube page, and they will live there. So that's probably a great positive that came out of COVID and doing the virtual events is that they get recorded and you can watch them as many times as you'd like. So if you want to go through the meditation from tonight or some of the questions that we went over or any of the wonderful talks. So thank you again for joining us. We hope you enjoyed our talks. And if you have questions, please reach out to us and contact us through these, either the phone number or the email. And if you have any suggestions for upcoming talks that you'd like to hear about, we would love to hear back from you guys. We hope you have a good evening, and thank you again to our speakers.